false positive here. So an SCO of 1 to 2.9. 95% of results are usually negative. Okay, this is on our assay. Now in England, they changed the guideline to incorporate our HCV antigen. So here, if reactive on antibody, they go on to test if the antigen is present, which indicates active infection. However, the deficiency here is still, if the antibody is unreactive, they consider the patient is not infectious or not exposed. So again, we prefer to see the antigen to be tested regardless of the antibody result. Which brings us to this proposed algorithm here, where you test simultaneously antibody and antigen in the sample. And based upon the result here, if non-reactive, truly we can say they are not infected with hepatitis C. If the antigen and antibody are both reactive, this is a current infection. If the antigen is detected but no anti-HCV, this is the acute window, the serodiagnostic window period, okay, acute infection, and you link to care. And then if the antibody is reactive and the antigen is negative, then it can be a resolved HCV infection because patients can be cured. Or it could be, again, mother-to-child transmission, if it is that scenario. Or it could be a false reactive anti-HCV result. Okay? So we believe this algorithm, once our antigen assay becomes available, this should be the one to really follow. Okay, so this table tidies it up somewhat. Okay? Any discussion on this aspect?
The last flow you had, the previous one is in the blood bank. If you come across this last one, what would you suggest for that? What is the bag of blood? Should it be kept aside?
Here? So antibody reactive?
Yes.
Now, if we look at the blood bank practice in the region, because they don't have our antigen assay, what they do is any sample that's antibody reactive, they discard, regardless if it's a false positive. If the patient tests repeatedly for the antibody, he will be deferred. Okay? Now, if the blood bag is non-reactive for the antibody, they test for RNA. Okay, because they don't have our antigen, they test all negative samples for RNA. So
my question was in the last column.
Here.
If the blood bag is positive for the antibody, and if the antigen is tested on that, and the antigen is negative or non-reactive, what happens to that?
Again, so we would
you consider him to be a treated resolved case or
for blood banking, I would recommend nucleic acid testing because we still have 2 or 3 days in between RNA appearing and the antigen, so it can still be there. And remember, hepatitis C can be asymptomatic as well, so the patient may never know that they recently were exposed to Hep C before they went to donate blood.
There may be a situation, for example, that the patient gets a routine viral marker testing pre-operatively, where antibody to HCV by the surgeon. And usually when we report it as negative, we have never telling the patient that you come and get the test done again after 2 months. Now suppose following the surgery, for something else, this patient gets that HCV testing done and it turns positive. The surgeon could well be implicated in the infection. It becomes medical.
Absolutely. So this is why we recommend you do consider the combination, and also again so in America, people will get sued very quickly, and they will do the RNA testing, okay, not just antibody.
your own staff. You can't pinpoint them. We can test the patient for HbA1c. If it is negative, the prospective patient may stay in the period and you are exposing your staff to. But sir, for an HCV infection, does the person give a history of jaundice?
No. Be asymptomatic. A lot of patients can be asymptomatic.
Because what we find for HPV, whenever the HPV case is developing a very high jaundice, he becomes negative, seronegative. Maybe he's positive earlier, but over a period of 8 months, 9 months, he turns seronegative. Is it similar in case of HCV also, that he turns negative in 6 to 8 months? If he has developed full jaundice, because most of the HBV cases which we see are silent, they never give history of jaundice. You just randomly check it out and it's positive for HbA1c.
I can't comment on the rates of jaundice amongst self-resolved HCV individuals. I need to look into that. I'm not aware of any data that we have on that aspect. So.
Most HCV are asymptomatic and they are usually chronic carriers.
They are chronic carriers.
This is what we have seen. Yes.
Even in liver injuries, minimal in HCV.
Minimal injuries.
Yeah, as you see in hepatitis B, same
Yes.
picture is
Initially.
never seen in hepatitis.
Yes.
It's B is more smoldering in
Yes.
nature.
Yes.
C is quite.
He has got more of ups and downs. Yeah.
Okay.
Sorry.
Now going on to hepatitis B here. So hepatitis B, I'm going to show you how you use the markers to diagnose and then stage the infection, and how they can also be used to treat. Actually, the last one, I don't have a slide for that. But this is a typical profile of a Hep B subject who resolves the infection. Okay, so after initial infection, the asymptomatic period during acute infection here, you have the elevation of the surface antigen. You may have the E antigen present because you do get mutants which don't express the E antigen. And then after the symptomatic period, the subject may go into recovery. So you'll have the detection of antibodies, the anti-HB core. For those who become truly immune, anti-HBs. And the anti-HBe, this may or may not appear depending on the E antigen status. Okay? And you also have the anti-HB core IgM. So this is an early marker, and the IgG is the late marker. So when a patient presents and you suspect it's acute HBV infection, if you run an acute panel of the surface antigen in the core, you can diagnose acute infection. Okay? Now, if you look at the profile of a chronic Hep B patient here, E antigen may or may not be present, depending on the mutant. Okay? The